morning, everyone. I request all of you to please be seated. Both of them are not working. Good morning, everyone. I request all of you to please be seated and be comfortable, and remember to put your gadgets on the silent mode. We'll be starting in a couple of minutes. everyone. Today is the 6th of October, a day of honor for all of us at the National Institute of Immunology. A day to celebrate what has been achieved over the years gone by, and a day to look forward to what is yet to come. Ladies and gentlemen, I am Banya, and it's my proud privilege to welcome you all to the 37th Foundation Day of the National Institute of Immunology. I, with the best wishes from the NII family, welcome our guest of honor, Professor Nikhil Tandon, Head of Endocrinology and Metabolism at AIIMS, New Delhi. It's our absolute honor to have with us today our founding director, Professor G.P. Talwar. Welcome, sir. And I welcome to the celebration our director, Dr. Devashish Mahanti. Now, may I request Dr. Mahanti to welcome Professor Nikhil Tandon by presenting a token of the warmest wishes of NII family. Thank you. Now, may I please call upon Dr. Pushkar Sharma to welcome Professor Talwar. Now, finally, I welcome a warm welcome to all the dignitaries joining us today, scientists, researchers, staff, graduate students, in celebrating and cherishing NII. Since its inception in 1981 to being formally established as a research institute in 1986, the National Institute of Immunology has been at the forefront of unraveling the intricacies of the immune system. Around the same time when NII was born, the British biochemist Cesar Milston, who won the Nobel for developing the hybridoma technique for monoclonal antibody production, said, and I quote, "Although the way ahead for immunology is full of pitfalls and difficulties, it is indeed an accelerating prospect. There is no danger of a shortage of forthcoming excitement in the subject. Yet, as always, the highlights of tomorrow are the unpredictabilities of today." This resonates with the NII family today more than ever. There has been no shortage of exciting research possibilities in these years gone by, and neither will there be in the future. We as a research organization have only grown from strength to strength. Cutting-edge research in immunology, infectious diseases, reproductive biology, structural and chemical biology, genetics, cell signaling, and cancer. We do it all here under this very roof. And we today stand tall as an organization with a vision to find solutions for global health challenges. This journey of decades has only been possible because of a rock-solid foundation, a foundation of vision, a foundation of knowledge, excellence, experience, and leadership. This is a day not just of celebration, but of memory and reflection. It's a day when we all stand together, look into the future, and ask, where next? And on that note, I now request our leader, the Director of NII, Dr. Devashish Mahanti, to deliver the welcome address to the House.
Thank you, Banya. Namaskar. Good morning. Professor Nikhil Tandon, our guest of honor. Professor Talwar, our founder director. All the guests and dignitaries, my faculty colleagues at NII, our students and staff, our alumni, and former colleagues. I welcome you all to the 37th Foundation Day ceremony of National Institute of Immunology. Every year, we have been celebrating the Foundation Day of NII on 6th October to commemorate the day on which NII was dedicated to the nation by the then Prime Minister in 1986. However, the true birth of NII goes back to years of hard work prior to 86 by our visionary founder director, Professor Talwar. We are very happy to note that like every other year, he is with us for the celebration of the Foundation Day. So he is not only part of the NII family, and his family also, all his members treat us as family, and I am happy that all of them are here. And NII Society was established in 1981 under the leadership of Sir Talwar, when government identified basic and applied immunology as a priority area. In the first decade of its existence, up to 91-92, NII made major contributions in the area of vaccine development, reproductive immunology, most notable being successful development of leprosy vaccine based on Mycobacterium indicus pranae, which is named after him because of his discovery. And it may be pertinent to note that utility of MIP is as an immune modulator has led to exploration of its efficacy for sepsis, COVID-19, and cancer immunotherapy in recent years. In the next decades, during 91 to 2011, NII further strengthened its position as a premier research institute in India and made innovative contributions in basic immunology, infectious disease research, virology, chemical biology, structural and computational biology, as evident from several high-impact publications. So during the last 12 years, NII has acquired cutting-edge modern infrastructure for research and has made notable contributions in cancer biology, systems immunology, aging research, glycobiology, structure-based drug discovery. NII has also initiated new research program in areas like virus immunology, single-cell immunogenomics, nanotechnology-based therapeutics, microbiome, organokines, etc. During this period, NII also strengthens its PhD program to attract around 25 bright and talented research scholars every year through a highly competitive national level entrance examination, which you hold almost in 20 centers all over the country. Apart from our publication and patents, the success of NII is also evident from the fact that 8 of our faculty members have been recognized by Shanti Swarup Bhatnagar Prize, the most prestigious award in Indian science, and NII faculties have a significantly high share in fellowships of leading science academies and in the country. 10 of our faculty members have been selected to take up leadership positions in other research institutes that include Dr. Rajesh Gokhale, who is current secretary of DBT. So many of our alumni are also holding senior positions in academics and industry and within the country as well as abroad. And I am very happy to note that this year, many of them have been able to join us for the celebration of Foundation Day, and this afternoon we are hosting an alumni reunion event at NII. So it is needless to mention that the success of NII is not only because of our faculties and research scholars, but also our extremely dedicated technical, administrative, and support staff. And I also thank Secretary and senior officials of DBT for their generous support to NII in all our endeavors. While it is natural that we take pride in our achievements, it is time for us to consolidate our efforts to get ourselves ready for future challenges. The COVID pandemic has made common man aware of the power of immunology. It is natural that NII will be expected to play a still bigger role in vaccine research and disease biology. It will be necessary for us to integrate laboratory research with translational health science and public health. In recognition of this challenge, flagship program on human immunology, a network program with in collaboration with clinical centers for genome sequencing of drug-resistant tuberculosis, and a collaborative research program with European Union for development of universal flu vaccine has been initiated in NII during the last 2 years. Such collaborative research programs in few other areas are also being planned, and DBT is initiating a very ambitious research program in the area of biomanufacturing for promoting circular bioeconomy. As a leading institute of DBT, NII has to strengthen its research program in the area of therapeutic antibody, new vaccine platform like mRNA, and development of precision therapeutic. And recent Nobel Prize for mRNA vaccine also encourages us to explore such newer areas. We also look forward, every year we look forward to this Foundation Day talk, which is very special to NII fraternity. And today's Foundation Day talk is by eminent endocrinologist, Professor Nikhil Tandon, who heads the Department of Endocrinology and Metabolism at AIIMS New Delhi. He is one of the top clinicians specializing in cardiometabolic diseases and is a leading clinician researcher who works in the interface of basic science and public health. He would provide us valuable insights into how to integrate laboratory research with translational health science, which have been goal of NII. And I must thank Professor Tandon for accepting our invitation for this talk at a very short notice. And I look forward to a memorable Founders Day celebration. Thank you, and thank you all.
Thank you, Dr. Mohanty, for a very comprehensive snapshot of our achievements and our plans ahead. I now call upon Ankita Yadav, our young researcher in a 5th year of doctoral studies exploring questions in pneumonia, to introduce Professor Tandon to the audience. Thank you, Banya. It is an esteemed privilege for me to be introducing our speaker for today. So Professor Nikhil Tandon is a clinician researcher. He is the head of Department of Endocrinology and Metabolism at the All India Institute of Medical Sciences and capacity building at the Center for Chronic Disease Control in New Delhi. Dr. Tandon's research interests include autoimmune thyroid disease, which includes thyroid epidemiology, diabetes, and metabolic bone disease, and the impact of early life events in adult chronic diseases. Professor Tandon has extensive experience managing large clinical and implementation trials. He served as the South Asia coordinator for the advanced study and is a lead investigator and a member of the steering committee for the NHLBI funded Center for Cardiometabolic Risk Reduction in South Asia trial. His group has also been working in the area of diabetes prevention in women with a prior history of gestational diabetes and has just completed the largest study evaluating the role of a lifestyle intervention in preventing diabetes in more than 1,600 women with a prior history of GDM across 19 sites in Bangladesh, India, and Sri Lanka. He has served on several WHO expert groups, including those for updating the WHO definition, diagnosis, and classification of diabetes mellitus and intermediate hyperglycemia, and the WHO Southeast Asia NCD Regional Technical Advisory Group, and more recently on the recently constituted WHO Technical Advisory Group on Diabetes. Professor Tandon is a former Vice President of the National Academy of Sciences, India, and a President and the incumbent General Secretary of the Indian Society for Bone and Mineral Research. He is an elected Fellow of the National Academy of Sciences, India, and a Fellow of the National Academy of Medical Sciences and the Royal College of Physicians of London. He has been associated with several international bodies such as National Institute of Health, Institute for International Health, and British Heart Foundation for research on thyroid epidemiology, diabetes, and metabolic bone disease. The Medical Council of India awarded him Dr. B.C. Roy Award in the Medical Teaching category in 2005. Professor Tandon was also awarded the 4th highest civilian honor of India, which is Padma Shri, in 2015. Among a big round of applause, I would like to welcome Professor Tandon for the talk.
Thank you so much for those very kind words of welcome. It's an immense privilege, not only the fact that I'm here for this lecture, but I'm doing it in the presence of Professor Talwar, Um, some of you may know I actually grew up on the Ames campus, so I possibly know him for as many years as I'm alive. Good to see you, sir. And of course, equally importantly, Pratap, Talwar's son, and I were in school together, so I think I possibly shifted to that school a little later, but I'm definite that at least from 1971 onwards, we traveled on the school bus together. So that's a few years now. And that is a long memory to take back. I come from an institution which for which Dr. Talwar serves as a bridge, because he obviously was our professor of biochemistry. I think the only time Dr. Talwar came second was when he was the second person to join the faculty of Ames, beaten by Dr. Nand Keshwani by a few hours or a few days, I'm not sure which. It was first before that, it's always been first after that. So of course, my only regret is that the year I joined MBBS, which was in 1981, I think, he was not there at the time, in the beginning of my first term, because he was still on his Jawaharlal Nehru Fellowship. And I think mentally he'd started shifting to NII by then. So we only got half of him to teach us. The other half was establishing this institution, and well, what an institution, a great job. Really, thank you so much. Let me just say that this is going to be a bit of a different Foundation Day lecture. As they say in cricketing terms, I've been a bits and pieces cricketer. I actually have some immunology credentials. Actually, my PhD is on the cellular immunology of autoimmune thyroid disease, so maybe significantly outdated, but I did 3 years of wet lab, and the name mentioned Cesar Milstein was 100 yards away from where I was, very long distance, 100 yards in terms of professional comparison, but he was very much there, and I can tell you he was an intimidating human being. So there you are. Let me give you a little backdrop of what I plan to do. So I will take you through our journey, which really has nothing to do with immunology at all. So those of you who are hoping to get a dash of immunology, it's a good time. There are 2 exits at the rear. You can leave at any point in time. What I'm going to, however, tell you is something which may be of interest to you as human beings, because as human beings we tend to fall ill, and unfortunately at the moment the problem of non-communicable diseases is such that it causes the single largest chunk of morbidity and mortality even in a country like India. So maybe 60% plus of all causes of mortality are because of non-communicable diseases, and unfortunately a lot of that is easily preventable, and we've not done a great job with it, as we haven't done for several other things. So we really need to figure out what we can do, and we've used a strategy to combine technology with task sharing and see if we can improve the ambulatory management of non-communicable diseases, and I'll take you through that journey. But let me just give you a sense of what clinical research is and the spectrum of clinical research. It actually does start from here, which is a large part of what is done in this institution, which is what is really bench, but then bench from a clinical perspective needs to get translated into impact on patient care, which is really the first level of translational research, right? So let's say work on the leprosy vaccine, work on the vaccine on HCG, goes from bench to what is its utility in human clinical interface, and that's T1. And then you go ahead and see how that impacts using larger scale clinical trials, and for that matter, even surveys and epidemiological work, which can give you a broader and scaled up sense of this work. And then you go to what is a T3 level of implementation, which is dissemination research. So again, taking things which were working in a relatively protected, controlled environment, where you have full control over all the variables, to a open system, where it's things which are way beyond your scientific control. And again, I'll give you an example, and Dr. Talwar, of course, would remember him. He was the person I refer to as Professor Ramalinga Swami. So he He's really the person who created what is now called as the National Program for Prevention of Iodine Deficiency Disorders. But clearly everybody knew that goiter and other thyroid problems were because of iodine deficiency. So, the science was done. The point was, how do you get that iodine into human systems, right? And that was implementation research. So in 1956, what they did is what in today's parlance, and the economists are getting Nobel Prizes based on that strategy of randomized control trial. What was really done was a cluster randomized trial in Kangra. Kangra was then part of undivided Punjab. So he essentially took 3 districts out there and delivered different salts in the 3 districts. One which had no iodine, one which had potassium iodide, one which had potassium iodate. But the question is, how do you ensure that the people take that salt? So that's where the implementation part came into being. So this was then made available through the public distribution system. Several of you are possibly not even old enough to know there were ration ki dukan. So, so ensure that that's what was being delivered. The second thing was, why would anybody take anything which was more expensive than what the other salt was to enable that? This didn't happen, the pricing was made equal, and this was ensured that it was given to every household. So the science stopped by the recognition of the role of iodine deficiency in causing goiter, but the science was inadequate in ensuring resolution of human disease. So there's a huge spectrum of research which is required, which clearly has its bedrock on basic science. I mean, there is no question about that. But to ensure that it really impacts on human lives and then impacts on the population at large, you need to travel through this entire journey of first from T1 to T2 to T3 to T4. And the last is basically implementation research or improvement science, which may have still some research, but a lot of other factors which come into play. So I'm going to give you a little sense of this journey which we've done over the last 12 years and see how we managed to travel through this to come up with something which now has a potential likely impact on health policy and health systems. So I've used 2 terms, health technology and task sharing, and I'll just explain these terms. So healthcare technologies is fairly simple. I mean, actually anything, whether it's medicines, medical devices, assistive technologies, techniques and procedures, any of that will fall into the broad ambit of healthcare technologies. Technology acts as an interface, and there's obviously very clear evidence that with technological advancement, there has been improvement in healthcare. I mean, that's a given, right? But what I will be speaking to predominantly is not the broad scope of healthcare technologies, but digital technology, right? So I'm not talking to you of new medication, new diagnostics, new point-of-care devices, but the role of information technology and digital medicine in what we plan to do. The second concept is task shifting or task sharing. Now, you clearly need to understand that there will be at lower level healthcare facilities the likely paucity of what we call physician healthcare providers, right? So the situation when you're using non-physician healthcare providers in a previously untenanted facility is task shifting. You've shifted work from a physician to a non-physician. And task sharing is when, though there are physicians available, you're reallocating some of the workload from a physician to a non-physician so that there is a team which is involved in healthcare delivery rather than an individual. Simple story, if somebody is coming to see me in the clinic, there's no reason why I should measure blood pressure, why I should take weight, why I should take height, why I should counsel those patients, right? My time is better served doing what only I can do, which a medically trained individual can do. And there's a lot of my work which can be offloaded. And therefore, even if I'm spending the same amount of time with the patient, that time is more dedicated to stuff which I could do, whereas all the other stuff has got offloaded to non-physician healthcare providers. So it's a way of improving the efficiency of the team as opposed to saying the same person is going to do everything from A to Z. Since I'll be talking of non-communicable diseases, I think it's important to understand that the management of non-communicable diseases is very different conceptually from the management of acute communicable diseases, trauma, even maternal and child health services for that matter, right? So when you have fever, it's symptomatic, you will go to a doctor, they'll diagnose malaria, they'll diagnose typhoid, they'll give you, 3 days of medication, 7 days of medication, you become better, chapter closed, nothing else, right? So that's acute finite care. What happens when you get diabetes or hypertension? It's with you for your entire life, right? So the way you approach a disease which is non-communicable, which is chronic, is very different. The problem is the way we were taught medicine was a very similar approach to everything, which is really wrong. And therefore, you need to understand that there is a continuum of care required for chronic non-communicable disease. And the continuum of care actually starts from the point that because these diseases are asymptomatic, you end up with a situation where first you have to screen people to diagnose them. You can have diabetes for 10 years and you may never know you have diabetes. You may have hypertension for 20 years, you may never know you have hypertension. But the problem is if you don't know you have a disease, you will never get treated. If you don't get treated, you will not keep things under control. If you don't have things under control, you will develop complications, eventually leading to significant morbidity and unfortunately even death. So the conceptual framework for managing non-communicable disease has to recognize the need for a continuum of care. And this is what I've tried to show in this particular diagram. Once the individual enters the health system or the health system reaches out to the individual, you screen them for diseases. At the moment, the government of India in the National Program for Non-Communicable Disease has identified 5 diseases for which everybody above the age of 30 needs to be screened. And these are diabetes, hypertension, and 3 cancers: oral cancer amongst both genders, breast and cervix in case of women. So those are 5 which is mandated, and therefore if you are part of especially rural India and a smaller city where the state health system is much more active, you will get screened for these. Then it's the responsibility of the health system to explain to you why you need to go up the ladder from screening to confirmatory diagnosis, initiation of treatment. Somebody has to ensure that you're doing what you were told to do. It's not good enough to write, ye dawai kha lena, 3 mahine mein aa jana. It doesn't happen, right? If you have malaria, you're ill. Whether the doctor tells you or not, you take the medicine yourself, right? Because you're clinically symptomatic. Here you don't feel unwell. Part of this committee which recommended these, and then this has now been taken up in the last World Health Assembly, May of 2022, which for diabetes has given these 5 targets to, as a part of the resolution of the World Health Assembly, and all member states have accepted this. So India is a signatory to this. That means by 2030, it has accepted that we'll reach these targets. Whether we reach them or not, at least there's an agreement that the health system has these issues. Now, there's a very simple rule which was initially taught about non-communicable diseases, and let's look at diabetes and hypertension because they are relevant for today's conversation, is a rule of halves. Half the people who have diabetes and hypertension don't know they have diabetes and hypertension. Half of those who know they have these disorders actually are getting treated. Half of those who are getting treated are actually getting controlled. So it's really less than 10% of people with diabetes and hypertension who actually meet control. It's about 8%, 9%, right? And that's how the rule of halves works. So the first thing they recognized was that 80% of people living with diabetes should be diagnosed. So we changed the paradigm from a rule of halves to a rule of 0.8, or 80%, right? 80% of them have good control of glycemia. So that's a huge jump. I said 8%. They're saying 80%. That's a massive jump. 80% of people with diagnosed diabetes have good control of blood pressure because a lot of people with diabetes also have hypertension. 60% of people with diabetes aged 40 or older should have their cholesterol under control. And for those people who have type 1 diabetes, which usually starts in the first couple of decades of life, which is dependent on insulin, 100% of them should have access to affordable insulin and equipment to monitor. Now, this is a tall order, but this is in front of us. This is the next 7 years, something of this description has to be achieved. What is the real status in India? And this was just work we published very recently, which estimates the continuum of care for diabetes using the National Family Health Services. Data is not ours, it's secondary data analysis from the NFHS, and you can clearly see the step downs, right? From here, it's going, you're actually not too badly off in terms of proportion who know about the disease, but then it's coming progressively down by 50% at every level. So we have a distance to go out here, and we therefore need to do something to fix this. Let me come to the sort of the key part of the technology, which is what we really added value in terms of a digital interface. And this is a clinical decision support system. Now, before I describe this, think of it from an algorithmic purpose, right? So if you're a patient, you go to a doctor, what do you really expect the doctor to do? Let's say you have high blood pressure, right? So in the mind of the doctor should be the following minimum information. What medicines are you already on if you were diagnosed previously? What is your blood pressure today? Based on that, should you just continue the same medicines if you're doing fine? If you're not doing fine, do you need those medications to be increased? If you're actually doing very well, can we reduce those medications? And the additional information they need is, are there any other comorbid conditions which may impact on the decision making for that? So really every doctor is doing a clinical decision support algorithm internally. We don't call it that, it's just decision making. But think of a doctor who's sitting in a primary clinic or a family physician, or even for that matter an MD physician who has to treat diabetes and hypertension, diarrhea and pneumonia, tuberculosis and acidity, and a range of disorders. To expect that individual to know the existing evidence-based guidelines for all these diseases and take good, correct, and evidence-based decisions is perhaps asking for too much, right? So if they get a clinical decision support which can help prompt their decision making, we thought it should make a difference. So a clinical decision support system really are computer-based programs that analyze data which are existing within the electronic health records. So it requires an electronic health record to provide prompts and reminders to assist healthcare providers in implementing evidence-based guidelines. If you're going to a doctor, you want that guy updated with today's knowledge, right? If he passed MBBS like me in 1985-86, you don't want him to be thinking of what he was taught 40 years ago and treating you. You want him updated. Now, it's not easy to get updated in everything all the time. So you get some degree of back-end support. It's highly useful, right? And it could be to advise you how to screen people. It could be to flag them, provide information on treatment protocols, provide and prompt questions on medication adherence, etc., etc., etc. Is this useful? It is now proven without doubt that clinical decision support system is amongst a best practice for health systems. So there is no confusion on that score. The question is, how do we make an appropriate CDSS and how do we get that integrated within the health system? So this is the sort of slide you're not supposed to read, but I think it's important for me to try and communicate the very simple process of. So in today's AI and generative AI worlds, these algorithms were prehistoric. These are rule or scenario-based algorithms, but we started like that, and they've actually shown utility. I'm not for a moment saying that transitioning to AI-based algorithms is not useful. Obviously, it'll be a next step going forward. But if you just look at, and without worrying about what's written inside, essentially what we did was make a grid, right? And we populated the grid along the X and Y axes with the variables we thought were variables of interest, right? So for example, for managing people's sugars, we said we'll look at fasting blood glucose along here, and we'll look at the HbA1c. The HbA1c is a measure of the average control of blood sugar over a period of 3 months. Now, the reason why you use something like that is, and if I'm a mischievous patient and I know I have a doctor's appointment coming up in a week from now, and I may have been absolutely non-adherent and non-compliant to my medication or my diet, I just need to fix myself for 3 or 4 days and get a fasting done, and that fasting value will be all right. But if I get a glycosylated hemoglobin done, very, very clearly, all the preceding 3 months of not being a good patient will become very, very clear. So it is a very useful tool for us to see, has the average control been good over the previous 3 months? Because just saying I've been good for 2 days is not good enough, because it'll eventually impact adversely on health. So we just created, and you can create these categories yourself. So we said a fasting glucose of less than 110 on this, 110 to 130, more than 130. And we had 3 values of HbA1c, less than 7, 7 to 8, 8 to 9. Again, I mean, you can play around with these numbers till you feel comfortable. And that basically ended up with 9 squares, right? Or 9 cells. And essentially what we said was, define that if you're less than 110 and less than 7 A1C, we're happy. You can continue with whatever medication you want. If you're more than 130 and an A1C is more than 8, it means terrible control and we really need to do a lot. And then a range of things in between. So essentially we had 9 potential broad categories available to us. You know, good control, perhaps things are not going so well, need some increment medication, need a lot of change in medicine. The other thing we did was, because we need to come up with a back end, is to say, what does it mean? How much do we increase, right? So there are a handful of medicines in diabetes. We define what 1 unit increment would amount to. So metformin is, for example, a common drug which is used in diabetes. You can go up from 500 milligrams to 2,000 milligrams, that's 2 grams. We said, okay, 1 unit increment would be 25% of the maximum dose. So 25% is 500 milligrams. So if you say we want to increase 1 unit, that means we'll add 500 milligrams of metformin. Or if the person is already on the maximum dose or maximum tolerated dose of metformin, we'll do a similar unit increment of any of the other agents. So we defined the scenarios, we defined what is the increment required, and we said for each category of medicine, what is that unit dose for increment, right? So not very complicated. Actually, it was done by a couple of us sitting. I know they use the word euphemistically, back of the envelope. It was actually one single A4 sheet. That's all. The problem was, that's all good, but no doctor is going to go and sit and see all this, right? What we then decided was to go and get some IT assistance. And we were looking around, and then somebody said, you know, you guys are wasting your time. Find a couple of young kids who've just fresh out of doing their, you know, BTech and CS, and who are interested in starting a company, and just let them roll. And that's what we did. We found 2 fresh IIT grads who possibly just come back after a short stint in the US. They, at that time, had a company called Health Chakra. I'm telling you all this because you'll possibly recognize the new avatar of that company today. And we were actually their first clients, and they made the back end for us. They're too big for us today. They're now called 1mg.com, right? So these are the guys who have now, from Health Chakra, become 1mg, and now Tata 1mg.com. But we are, and so I still claim that, you know, we gave you your first paycheck. And so that's how the software was created. We did something very similar for blood pressure. Again, just fractionating the systolic pressure on the one side, the diastolic pressure on the other side, and saying, okay, good control, not so great control, bad control, terrible control, and increase the medication by 1. And really, that's what I do in clinic even without this, right? If I see somebody is doing well, I'll say, okay, fine, continue the same medicines. If I say that, you know, things are not going so well, if I know that they've been adherent to medication, I'll say, maybe we'll increase your medicines a tad bit. If they're really badly off, I'll say, I think we need to increase your medicines much more. Right? So these are prompts. And we did the very same thing for cholesterol. And that's what we made initially, because our very first effort was to look at people with diabetes who had poor control. So now let me take you through, after this background. So we've understood the need for a continuum of care in non-communicable diseases. We've talked of healthcare technologies. We've talked of task sharing. And we've talked of the digital technology component which has come into play. Right? So really, the task sharing part and the technology part are really shown out here. and we created a human entity in our mind, right? And this wasn't a fix. It's not like, you know, there's a designated post. Let's say this is a government of India has a post called care coordinator, nothing. We just created in our mind, and we call that entity a care coordinator. And this person was our primary interface with the patient, and I'll show you that in a moment. And what we said was this person will coordinate the patient's care, will be the receiver of the patient, will do the initial work, and then will close the loop when the patient comes out after seeing the doctor, right? And the technology, as I mentioned to you, was an electronic health record. This work was started in 2008-9, and electronic health records were not available. We actually created an electronic health record, and then we created a clinical decision support software based on the information I just gave you. So this is what we've done in the last 12 or 13 years. So the first 3 projects were really variants of what you'd call conventional research projects, right? So the first one was in tertiary care. We called it the CARS trial. It was a Center for Cardiometabolic Risk Reduction in South Asia. We ran this in 10 sites in India, about 1,140 odd patients. And the entry into the study was you had to have diabetes, you had to have poor glucose control, and we defined that. And in addition, you either had to have uncontrolled blood pressure or poor control of cholesterol, or both. And the outcome we wanted to see was whether what we were doing would have all their targets well under control. We also said that you can have comorbidities. So later we actually did the same study in people with diabetes who had comorbid depression, because they both, you know, so if you're depressed, you don't really adhere to your diabetes lifestyle well. And if you have chronic disease, you're bound to have depression. So we needed to look at that. The second was at the level of the community, and the third one was at the level of what is called secondary care institutions. So those of you familiar with the government health system, these are called community health centers and district hospitals. One is at the level of a block or a taluk, and the other one is at the level of the district. So these were done, as you can see, over the first 7 or 8 years. Based on these data, 2 states in the country, Mizoram and Tripura, said, this is interesting. We will take up this model for care in all our secondary care institutions. So all community health centers and district hospitals, which is about 56 or 60 in number, in these 2 states, actually started delivering care using our model, in which there was an entity called a care coordinator, but really what they'd done was they'd repurposed a nurse. The nurse, there's the things called the NCD clinics, which are supposed to be there at these institutions, paid for by the government. So we were not adding manpower resource. They just repurposed that person to deliver care as we decided, and we provided the electronic health record and the decision support. We've since then now done this at a demonstration project in an entire district in Punjab, going through all levels of care, primary, secondary, and tertiary. And I will now take you through this story before I wrap this up later. So on the left here is really what happens when you as a patient, or I as a patient, go to a doctor, right? You go to the clinic, private or public. You first go to a registration area. They say, I've come. You then, somebody will, you know, maybe see your labs or see your height, weight, blood pressure, etc. Then you will go to see a doctor who will review those results, have a look at you, say, do this, this is your prescription, take this much medicine, this dose, this many times a day, and say, I will now see you after 3 months. Before you come, please get these following investigations done. In reality, number one, nobody knows if the patient has understood a word of what the doctor has said. Number two, nobody knows whether they'll even buy those medicines and take them in the way you prescribe. Number three, whether or not they'll come back after 3 months as prescribed, nobody has any control over that. And even if they come back, will they come back with the requisite sort of interventions and investigations? So in reality, it's like saying, हमने अपना काम कर दिया, अब मरीज का काम. You know, which is not really fair. Which isn't really fair, if you ask me, okay? So, and of course, then you go out, if you're going to a private care institution, you have to pay a consultation fees. I forgot that, that's important. What we did was we've changed this whole structure. So we said, we will put the doctor aside, we'll create this non-physician healthcare provider, and for the first study, we actually created the entity because it was a research project, right? So we hired people for it. And what did we say? We said we don't want anybody fancy. Anybody who's done a first degree, undergraduate degree, BA, BSc, who knows how to use a computer, because they'll be entering data, and who has some communication skills, you know, who can talk to individuals. Uncle, auntie, aap theek hai, tabit theek hai, you know, whatever, that sort of stuff is very critical. Remember, in India, you must also understand that unfortunately there's a socio-economic and, more importantly, an educational divide between doctors and patients, right? For 80 or 90% of your patient clientele, they actually think the doctor comes from another planet. It's a big gap. And therefore, for chronic disease, for them to open up in front of the doctor is not common at all. And for chronic diseases like this, there are so many things happening back at home which have a bearing on their disease. बच्चे का 12th board आ रहा है, बेटी की शादी है, somebody is ill. You know, there are about 500 such things which can be happening behind, which are impacting, and which clearly may or may not be modifiable, but it's important for you to know as to why somebody who's doing well suddenly has started doing so badly in terms of disease control. And that's the sort of information which a person like the care coordinator is very, very useful in eliciting. Because the patient thinks, ye to hamare jaise hai. I'm sorry for sounding a little classist out here, but this is the reality of, and there's much more which comes out in that conversation, right? And that's very useful for briefing the doctor. So the patient would come to the care coordinator, have their usual chats, they would bring their blood test reports in, they would be entered into the system. If any blood pressure had to be measured, that'd be entered. And the clinical decision support software then actually just gives an advisory. And with that advisory, the patient goes to the doctor. Now, imagine it's in a teaching hospital, this is the equivalent of a junior doctor doing the early work. But junior doctors are expensive as opposed to this care coordinator, right? So if I was in private practice, I'd save 70% or 80% in salary costs by replacing a trained junior doctor with somebody who's a care coordinator. That's very important if revenue generation is central to my role. Based on that, what we told the doctor was, this is what the clinical decision support management prompt is. It's an advisory. Eventually, you have to write the prescription. You have to be comfortable in doing what you have to do, right? You don't agree with the advisory? Don't do it. But since we're doing research, small request, just say why you are not accepting the prompt. Because we should know, A, is there a systematic problem in our algorithms that, we're not picking up this issue? Or is it that the algorithms will never, let's say, beti ki shadi cannot be a part of an algorithm. It's not humanly possible for us to create a scenario which says, amongst the things at the back end that you have to inquire every time from the patient, ghar mein kiski shadi ho rahi. It's very difficult. It's very difficult. Maybe AI will fix it, but rule-based algorithms cannot fix it. Right? And then the doctor gives their advice. The patient goes back to the care coordinator who explains the advice and says, I'll fix the appointment for you. If you need help with the investigations, we'll get that done and go back. So this is really the package. It's not a technology package. It's a task sharing plus technology package. The first thing is for us is very important to understand that. So this was the sort of stuff which came. This is the A1C, this is the fasting, this is the PP, whatever. Likely poor control. This person was on insulin. So the advisory was increase the insulin dose. The doctor said no because the patient said, Doctor Sahab, main 3 din Vaishno Devi gaya tha, main dawai to le nahi gaya saath mein. Now going to Vaishno Devi, it's not easy to put into an algorithm, right? So everything cannot be fixed algorithmically. You need still some basic conversation. But that's what happened. And same thing for blood pressure, same thing for cholesterol. So all I'm trying to say is before we get swayed away that IT is going to fix everything, our algorithms clearly had a gap. Maybe today's algorithms as we evolve will be better, but still there will be a gap because human nature is human nature and you really have limited control over that. So this is what we achieved. This was a an individually randomized controlled trial. It's called a probe design. It's a pragmatic trial. It's randomized. It's an open label study because, people obviously knew what they were getting because we're not using medicines, right? So they were either randomized to getting task sharing and the technology part or business as usual. But the endpoint evaluation was blinded. So it's called probe, pragmatic, randomized, open label, blinded endpoint adjudication. And this is what we saw. If you look at this row, this column, normally people say that this intervention improved things by 30%, 40%. Our intervention improved things by 240%. It was the likelihood of achieving multiple targets was 2.44 higher in those who were randomized to our intervention as opposed to business as usual. The absolute numbers were still very, very disappointing, but they were, as I said, instead of 8%, we reached 18%. Which is great. And that 8% was for glucose alone, for multiple targets is way lower. So again, I'm importantly pointing out this is not enough as an intervention, but this is clearly substantively superior to what had been done before. Did this decision support system work or not? This is a very important question because people will say that it was a composite intervention. You were really not powered to dissect out individual interventions, but we did this nonetheless. And if you look at each of them are in the same way, right? On the extreme left is when all the prompts were rejected versus extreme right is when all the prompts were accepted. So extreme phenotypes, but that's how people can actually evaluate. Very clearly, whenever the prompts were accepted, the likelihood of better glucose control, better blood pressure control, and better lipid control came out very clearly. I mean, you don't need stats for this. The eyeball is telling you everything out here. Very, very clearly, it was something which was significant. There was a 0.5% difference in A1C, which doesn't sound a lot, but the intensive trials got a 0.7% A1C difference. This was just a change in strategy. And for a process change trial, a 0.5% A1C is spectacular. Systolic blood pressure was nearly 20 millimeters of mercury different in those in whose prompts were accepted. And there was a 40 milligram per deciliter difference in LDL cholesterol. So massive impact in those numbers. Unfortunately, not enough people had those impacts, right? And so very clearly the physician, we actually then went and talked to physicians doing some qualitative and mixed methods research and said, guys, this was a trial. Supposing tomorrow we offer this to you as standard of care in your clinic, will you take it? They said, we'll take it. Any day we'll take it. Because it really, really helped us significantly. So this was tertiary care, right? Now, tertiary care, you would have expected you had, padhe likhe doctors sitting in medical colleges or in corporate hospitals. We still got a benefit out there, which doesn't say much for padhe likhe doctors, but anyway. So this was from Solan in Himachal, which is secondary care institutions. And I'm not going to go into numbers. There was about 7,000 people who were eventually subjected to this. It was a different research design. We call it a quasi-experimental design, pre and post, and we looked at differences. But again, looking at that, you'll find that starting blood pressures and ending blood pressures, there was a 20 millimeters mercury difference. 20 is massive. A 3/2 difference in systolic, diastolic changes event rates by 20, 30, 40%. 20 millimeters of mercury is like, it's a totally different world. And this was the difference in fasting glucose. It was a 30 or 40 milligram per deciliter. So again, huge impact, right? So we then said that we've looked at primary care separately, which I haven't shown you the data, secondary care separately, and tertiary care, but we're in India. We're an anarchic country. You can't convince anybody to go to where they should be going. People will go to whatever hospital. So if you live in Green Park and you sneeze in the morning, you'll say, chalo AIIMS chalte hain. If you're sitting in an outskirt village or far away and you're dying of cancer lung, you're still struggling to get even half decent care, which is ridiculous as far as I'm concerned, because you're not really aligning patient. Eventually, it has to be the patient's requirement. So you're not being able to align patient requirement with skills, competencies, and resources. So we've got to figure out a way. You can never compel people to go wherever. This is, as I said, this is India. We do what we want to do. But if you can align and nudge them that even if they land up at a higher level of care, manage them, but gently then push them down to that level of care where they can be still stable, and that's near their house, it'll be a great difference. It'll decongest tertiary hospitals from the sort of patients who can be managed very well at primary care, and will allow those people who really needed tertiary care to access tertiary care instead of languishing at the bottom of the pyramid, which is critical as far as I'm concerned. Otherwise, why do you have a health system? You should have one type of hospital which serves everybody for everything. So we decided we'll take one district in Punjab, was nearby, we could talk to people out there, and take a block and look at our intervention across all levels of care and compare it with another block in the same district, because then it has the same district administration, same deputy commissioner, district magistrate, whatever they are called, and let them continue with business as usual. So this is what really happens today in the National Program for Non-Communicable Disease. We've been working within the governmental framework, because scaling up, you can scale up with the government. Without disrespect to private healthcare, there is great private healthcare in lots of places, but there is no system. How do I scale up? Because if Apollo agrees, it doesn't mean Max will agree. So there is no uniformity in scale up. If Madhya Pradesh agrees, then everything in Madhya Pradesh will be under the same system. It's very different as a paradigm. So this is what is actually supposed. The national program, as I said, has these ASHA workers who actually do a checklist for your risk factors. Then the auxiliary nurse midwives are located at what is called a sub-center. They do a screening. Those who screen positive for diabetes and hypertension, which is my area of interest, will then be sent to a primary health center where they are confirmed. They start treatment, and if required, they're referred. So we had this backdrop to insert our thing. And as I already mentioned, we had an electronic case record form, and this time we were smart. The government, you may not realize, actually has what was then called a comprehensive primary healthcare NCD portal, and today is just called an NCD portal. So there exists a back end of digital forms. Whatever the uptake may be, it exists. So we said we'll take the same forms, create a pack of clinical decision support algorithms, integrated with that EHR using APIs, and we're up and ready to go. And if it works, all that a government needs to do is flick a switch from a, it's like VXI ko LXI kar do, ya LXI ko VXI kar do. I don't know which one is higher, but basically you just go up to the next model of care. It's as simple as that. We, of course, trained the healthcare providers, and we slightly changed the workflow in the facilities. The patient went to the nurse, got all of this done, then went to the doctor, and then back to the nurse to close the loop. Only for NCDs in NCD clinics. And we did a lot of background work. We did about 8-9 months of formative research. We went and visited every single facility in that block, made an inventory of every single, we actually knew better than them what they had in the facility, what medicines they had, what diagnostics they had. We actually knew exactly how many days in the week was a doctor present, how many days in the week was a nurse present, which is not every day, by the way, right? So we actually had all of that information, talked to a district administration, lower level administration, state, and then we came up with this intervention with the aim that we will increase the use of a CDSS-enabled Government of India NCD system, improve the involvement of doctors, provide referral linkages. I'll come to that because this is the critical bit, and doing task sharing. Now, obviously, if I use fasting and HbA1c in a tertiary care center, the primary health center has perhaps never heard of an HbA1c. We leave aside having one. So we made a slew of algorithms. If koi bhi sugar ho aapke paas, we will trigger off an algorithm. So depending on what the electronic health record has, that information can be picked up by the algorithm, and it obviously will be the better the information, the better the algorithm, right? But it's going to be still some advisory coming up. Blood pressure is simple. Wherever you are, you just need to measure it. Whether you are at the house or at an apex tertiary care, you still need a BP instrument. So we could actually fix that without difficulty. So we made these algorithms. The only other thing we stratified was There are something called the Indian Public Health Standards. We said that only these two medicines are available for hypertension and diabetes at PHCs. So our algorithm advised only those two medicines. For the community health centers, some more medicines. For the district hospitals, some more medicines. So that was the degree of alignment we did. And that's really the pyramid starting from the ASHA and going upwards. So this is really what the story is. There's an electronic case record form which pushes information to the CDSS engine, and the CDSS engine then sends back a personalized management plan. It happens in real time. The doctor does nothing. They can then modify the prompt, right? But they don't have to do anything because they have already got this advisory by the time the patient reaches them, because all this work has been done by the nurse. You know, doctor कहते हैं हम नहीं कर सकते, हमारे पास time नहीं, ठीक है नहीं करो. We're anyway not getting you to do it. We're getting the nurse to do it. Right? So patient walks in to the care coordinator, does all the work, medical officer sees it. Whether or not they accept or don't accept, again we leave it to the doctor, but if they rewrite the prescription, again we wanted information from them, and then off they go once again. Right? They actually get a printout like this. It's quite neat. It's actually quite neat, right? And the printout will combine the status for the day and provide a prescription. This is Sarkari. I'm not talking of fancy corporate. This is primary health center level prescription printout. I mean, I know you guys won't believe it, but this is it, right? So the first thing people said, "ठीक है, बना दिया." How do we know anybody is doing it? Which is a very critical question. Implementation research requires not only that you have a fancy tool, but it has to have an uptake. And the only way, so we did things which are called patient exit interviews. So patient would come into a facility and we'd look at them at the registration and say, if you're coming for diabetes, hypertension, after you've seen the doctor, ek bari humse mil lena. And we'd capture information to confirm that all this work had been done, and which of course in India anything can be fudged, right? My field worker can be making things up. But the important thing was that anybody who got a printout prescription could not have got a printed prescription unless and until they went through the digital system and the CDSS was used. So the moment we had a printed prescription, it means there had been an uptake. Obviously the backend would give that information also, but pending that, in real time, we could actually get this information. And the uptake varied from 70 to even 90%. It went down to 70% because of one facility, the doctor was away on maternity leave. But really, uptake was far in excess of what we'd expected. So what we managed over this period of time is create this whole system in which you get a personalized clinical management plan, you identify high-risk patients, you identify patients who, if the backend gives you information that they've got, let's say they've got a kidney problem also, then these are the medicines which will not come up in the prompt. Because in a person who has a kidney problem, this won't come up. If a person has, you know, chronic obstructive pulmonary disease, these medicines will not come up because the backend has already identified that having this medicine is going to be bad for the patient. Even if the doctor doesn't remember, it's coming up out there. So it really helps. And the most important thing as far as I was concerned was, and I already told you there's an hierarchy of institutions. When is it that you should actually send the patient to a higher level of care, right? At the moment is entirely discretionary. I think this person should be sent up to district hospital. So we can objectivize that. We said if you're meeting this threshold, you're already on maximum medicines available at that level. Let's say 2 medicines for blood pressure at a primary health center, and your blood pressure is not controlled. We recommend the patient is referred up. So there is an objective trigger. The same information is available through the back end to the level of doctor above, so they know this patient is being referred. It also goes to the ASHA worker and the A&M in that area, who then can follow up with that patient, says, you were told to go to the community health center, have you gone? So we've identified referral thresholds, we've done referral facilitation, and we've strengthened referral linkages, right? And similarly, once a patient goes up and their blood pressure gets controlled, we get them to be referred back down for stable management, so decongest district hospitals. So it's a full loop happening out there. So clearly it worked and all these, and I'm not going to waste time on saying that, but essentially the whole concept of task sharing and technology provided us a model of care for non-communicable diseases. We are academics, we like papers as much as any of you in the audience like writing papers. I mean, it's bread and butter. So we actually published a lot of papers. So this was my original slide, and I'm wrapping things up now. So we, in addition, the WHO has a package of essential non-communicable disease interventions, or the pen pack. We converted that into a mobile pen pack, and the Maldives has this now as its standard of care. What do we want to do now? Clearly, we've done a demonstration project in one block of one district of one state, right? But we're integrated with the national health system, right, through the portal. So obviously, our aim would be to scale up by formally integrating as opposed to integration in the project mode. The second thing which would be really useful for us, and we are in conversation with the national health authorities to get some money. So at the moment, our package was integratable with a certain electronic health record. We want to create a package which is agnostic of the electronic health record, right? So irrespective of whether it's an Apollo system, a Mac system, or a Fortis system, or a Medanta system, our CDSS should get plugged in out there. And I'm just using the name of those 4 hospitals randomly, not saying that they're going to do it, but it shouldn't be that for every time a new state which has a different electronic health record system wants to take it, we go through the, the construction of the, or reconstruction of the algorithm framework. So that's another important thing for us. And obviously, integration with what is called the ABDM, the Ayushman Bharat Digital Mission, using the Abha ID is critical for scale up in this. So actually, again, I mean, there's been a huge amount of digital work in the country, and just giving you a sense, there is, when we started our work, the National NCD portal was, Tamil Nadu said, we know what to do, we don't want central government. Andhra Pradesh said, we are so far ahead, we don't want. Kerala said, of course, we're not bothered with what the center does, we'll do what we want. Gujarat had its own things. We had about 50 different electronic health records working in the state health system. Today, 31 states have actually taken it up. Tamil Nadu has transitioned to the state, to the central one. Himachal has transitioned. 3 states have their own, but are still sending aggregate data, but that's it. Nearly 50 crore people have already been enrolled. Now, 50 crores is a lot of people in the country, 130 crores, and there's a lot of children and adolescents. So remember, this works for people who are 30 years and above. So theoretically, our aspirational goal, which is clearly mad, but there's no harm in thinking large, is to get integrated into all of these and get going. And there's actually a dashboard which anybody can log in and see, which actually gives you information, right? So today, if you're a health administrator sitting in capital city of any state, you can actually get by number all the details of what's happening in the health facilities from an NCD perspective. Right? I'm not talking of everything else. So our sort of massive achievement, I would say, has been that the national program released its new operational guidelines in May 2023, that is 3 months ago, and the clinical decision support system, as made by us, is now an option available to any state which wants to take it up. Of course, this little problem here is that they've changed the back-end architecture, so we are stuck. We'll have to work for some more time to now get it integrated. But clearly, that is a validation of the concept of a task sharing with a clinical decision support model. And that's where it says, gives you a good sort of thing on us, saying that this is something which is. So I'm going to stop here saying that while I've spoken, I possibly represent a very large group of people who worked, as I said, for at least the last 12 years. Obviously, colleagues at AIM, but we've had people at the Center for Chronic Disease Control, which is a research NGO, which is again started by people from AIM, and there's a lot of interface. The National Health Mission, the Government of Punjab. As I said, we work with the World Health Organization, with the Maldives. Now they're really ramping up their system. We had foreign collaboration in the form of Emory in Atlanta, the London School of Hygiene and Tropical Medicine. Dell is actually a Government of India partner. So they are the ones who've been given the job of making the back end. Tata Trust is the people who supplied money to Dell to do it and also take care of training. And FinAli is a startup which some of my younger colleagues who started who are now looking at exploring this to take it up on a commercial scale. But obviously, as I said, there's been a huge amount of lot of people who've contributed to this work, and I really want to put on record my gratitude to them. And stop here. Thank you so much.
Thank you, Professor Tandon, for that absolutely inimitable lecture. Do we have time for one or two questions? Can we do that?
If there are any.
I'm seeking your comments on two queries. You showed one table with respect to hypertension, BP, and so on and so forth. And that's the metric which you use when you manage the hypertension in patients. Does this metric changes in the age of the patient?
So it won't change with occupation, but definitely with comorbidities, it will change, right? So a healthy 70-year-old is the same as a healthy 50-year-old, but unhealthy 50-year-old may have more issues than a healthy 70-year-old and vice versa. So age will also reflect in blood pressure in some ways when there is much more likelihood of arterial stiffening and therefore higher systolic pressures. But usually the bigger matter of concern is what are the additional diseases which that person carries, because that may have a bearing on what you can give and what may not be such a good idea. So in a smoker who has bad lungs, giving a beta blocker is not a good idea at all, and that will come up in the back end. So this, but your question is absolutely valid that these were starting. I just gave you an example of an algorithm. These have been worked on since. Nothing is sacred. The feedback will only make it better. But yes, there are lots of other backend. I've tried to make it simple, but there are lots of issues. Whatever is captured by the electronic health record, if it doesn't capture that information, the algorithm will not work well.
Now, my second query is with respect to, based on your clinical experience, if you have two sets of people, one having only hypertension or diabetes, and another set of people who are having both hypertension and diabetes, they are being properly managed. Which particular group you think in your, based on your experience, will have higher probability of getting old age related issues like retinopathy or kidney disease?
So from a
one supplement the other or accentuate the clinical symptoms with respect to the age?
Risk factors are always additive, right? So the longer the duration of diabetes, the more likelihood that you will have patches of poor control. So duration is important. That, in addition, you had uncontrolled diabetes alone, but well-controlled blood pressure and well-controlled cholesterol versus poorly controlled diabetes and poorly controlled blood pressure, but well-controlled lipids, or everything poorly controlled, the likelihood of risk factors clearly gets magnified. There is no question about it. And therefore, I think the message, which is not relevant here, but from a clinical perspective, is that managing a person with diabetes is not the same as keeping their sugars under control. You have to fix all of these things because each of them will contribute to risk factors and vascular disease.
How do you put some of the usual clinical symptoms for each disease in the data?
So really symptoms are, we worked on the principle that this is asymptomatic disease, which is, so we actually said even if you have no symptoms, we need to fix your problem. Because waiting for symptoms in diseases like diabetes and hypertension means you're possibly not even treating 50%. So the starting point is screening so that you're actually bringing more people into care rather than waiting for people to have symptomatic disease and then starting care. And eventually, if your blood pressure is high, whether or not you have symptoms, it needs to be fixed. When your sugars are high, whether or not you have symptoms, it needs to be fixed. You may have additional tweaks, but the decision making is driven primarily with data. which in the case of blood pressure is systolic and diastolic, in case of diabetes is the glucose and HbA1c. Everything else then gets layered onto that. But that will remain your central trigger for this. Even forget about this. In the clinic today also, that's what is really done. Over and above, there are specific symptoms which may require specific management, but then I will first see their numbers before I take a decision.
So I do agree, but now since you have drug-based system, you can have one parameter, it can be optional one for the clinical symptoms, so that things can be much more precise.
I'm not sure symptoms add precision. I'm not sure symptoms are very important to get a sense, but I'm not sure the word precision is appropriate for symptoms, because as I'm saying, if you look at both sensitivity and specificity of a symptom, it may be specific but may be so insensitive that it really makes no difference. Right? So people may come to you with a diabetic retinal problem who never knew they had diabetes, because for the last 10 years they didn't know they had diabetes. So, their symptoms became really irrelevant because for 10 years they didn't have symptoms, or at least they didn't notice their symptoms. So I think again we've got to look at chronic non-communicable disease from a lens of asymptomatic disease as the core decision-making process. Yes, symptoms if there is a particular symptom, for example, if somebody is having, burning of their feet, that gives us a trigger for another add-on therapy, no question about it. Absolutely agree. But in terms of that will not make any difference to how I control their sugars. I will still control their sugars based on them.
But question is, since we have already dropped by,
Thank you, Professor Sen. We can take one last question.
Excellent work, by the way. And just wanted to know about the data accessibility. And why I'm asking is, we have tons of electronic medical records from Western countries, by and large owned by IBM. As simple as that, and you have to pay a hefty amount of sum if you want to access that data. But that's really helpful for retrospective analysis of the electronic medical records. So at least in academic institutes, the data can be utilized to different to create different pipelines, different frameworks for drug repurposing or novel drug recombinations, or even judging the best combinations for non-communicable diseases. So how are you planning on data accessibility?
So I'm going to give you a clear perspective on this. As researchers, what have we contributed? The electronic health record is not ours. In the project-based studies, it was ours, and that was open access, really open. So that was not a problem. The current electronic health record system is Government of India, right? So data capture and data ownership, as the government believes, is theirs. The clinical decision support system was ours, but the CDSS does not hold any data, right? It's pushed into CDSS, and CDSS sends a prompt back. So there is no retention of information in the CDSS. The short answer to your question is, I think it's a very valid question. I think there is a lot which can be done, but there has to be a governmental decision on what can be released without, and now that the data privacy bills are coming through. So anonymization, they have to come up with a policy on anonymization and share. That has to be done. I totally agree with you, but I'm not sure how much has been made available. So now, we don't have access to backend.
No, but you should, right?
There are lots of things which should happen.
Okay, brilliant talk, Nikhil. If Banya allows, I was completely blown away. 50 crore people. Have they been individually truly screened in this program across the entire country? And then how we in Delhi are not aware, are we also mandatory supposed to be screening, or is this a population-based kind of, I read up a little bit while you were speaking, is this only in villages, is this for urban areas, and we'd love to know more about it.
So let me just make this little thesis out. So there is a concept called enrollment, then there's a concept called screening, then there's a concept called diagnosis, right? Enrollment clearly means that the ASHA worker has got your name onto the system, which is the starting point. Now, what we did there also was, I'll very quickly tell you, that the ASHA used to do a paper-based checklist and create a family folder, which was a paper folder. So in Punjab, we said it's a, and then the A&M in the sub-center would digitize it. So there was really a duplication of effort. So we created a mobile app, converted the CBAC form into a mobile base. So the ASHA did it in one go, and the A&M's work got taken away. So at the moment, those 47 crores or whatever the number was exist by name and have an ID on the system. Not all of them have got screen, right? But they need to be screened. So that's the answer to the first. But you know, it's still a great start as far as I'm concerned. The second thing is, it's the rural health system works better in terms of governmental buy-in, right? The hope is that with an Aadhaar ID, as and when people get an Aadhaar ID, even if you're going to, I'm not sure, I think NII had a clinic at least at some point, or whatever. Let's say you go to your doctor and you have an Aadhaar ID, that information is available then on Aadhaar ID. The plan for the National Digital Health Mission was that the data is there, right? So today, let's say you go to your nearby doctor, that data is there. Tomorrow you have some other issue and you go to a corporate hospital. With your consent, that information can be made available to that. The ownership is yours. The ownership is yours. It's like a DigiLocker for health. The ownership is yours, but the access with your consent can be provided. So that's how the digital health mission is going to eventually pan out as and when it does.
That will have to be the last question. And with that, please, I thank everyone for a very engaging discussion. I now request Dr. Mahanti to join us on stage to felicitate Professor Tan. I now thank everyone for joining us. I thank our guest of honor for making time to join us today and for that brilliant lecture. I thank our founding director, Professor Talwar, for making this absolutely special for the NII family by gracing us with his presence. I thank all the dignitaries who have joined us today, NII alumni, scientists, researchers, staff and students, and each one of you for joining in these celebrations. Lastly, none of this would have been possible today without the efforts of each one of us from the NII family. Please join me in applauding the stupendous contribution of the administrative and the technical staff, the scientists and the graduate students, our senior manager, Dr. Vashish, and our director, Dr. Mahanti. I invite you all to the Foundation Day lunch. It is being served in the playground, and to join the day of festivities with us. Thank you.